lot of people don't really understand how many people are living in America who are aware of their HIV status, so they've been diagnosed, but they are not linked to care necessarily, or those who are then fall out of the system. So the issue really is one of retention, a crisis of retention in care, correct?
Yeah, at the end of the day, only 1 out of every 2 people who actually gets tested and starts medication stays on medication. And those are pretty lousy odds, lousy numbers. And so what we've done at the fund is we've created a program that we're announcing, we announced actually yesterday with Secretary Sebelius, that looks at retention. And we've always worked on retention because we fund a great deal, about $5 million in food grants and about $4 million in housing grants.
So all the supportive services.
All the supportive services.
That make it necessary, that are necessary for someone to be able to take care.
And if you look at the LA County data, if you look at all the data, if you look at David Holgrave's data around housing, food and housing or prevention, because at the end of the day, if you don't have a roof over your head and you can't eat, you're certainly not taking your medications.
You're not worried about long-term health.
Practicing prevention.
Right.
So what we have done is basically given HRSA money to take a look at a model, Text for Care, that has worked in other countries. And the model is essentially that folks are texted, reminded to take their medication, and they're also reminded about doctor's appointments.
So their phone is going to help them save their lives.
Yes, basically. And we know from our own lives, from almost our inability to lift our head up from our phone, that so many people live from their phone, and that many more people have access to phones than they do to computers.
Including disenfranchised people, which are, the group of people that we're really trying to reach. Because I think a lot of people also, as you're saying, people who don't have housing and who don't have food and who are living in places where they don't have transportation or childcare, all those other supportive services that are required for someone to go to the doctor or go to the pharmacy, often, no matter what, they have a phone. So we can reach people, we can take medicine to them.
So that's one terrific model. We've also funded a program, a global forum, that is going to basically bring together, with a partnership of the Department of Health and Human Services and PEPFAR, many African countries have better retention rates than the U.S.
Which is shocking. And why is it better abroad than it is here?
Well, a couple of reasons. One is, in fairness, we have much higher resistance rates in the U.S. Because we had meds earlier. So there were more people who went on meds and failed. And so if the medication isn't really working, obviously you have less of incentive to keep going on it, or if it's harder to take and multi-step. We also honestly have folks who are more disenfranchised in the U.S. in terms of, not all folks are gay and bisexual men or injection drug users or sex workers, but that's a big chunk of the population. And it's harder for those folks. They have a lot of survival-based needs that come before taking their medicine. And
it's shocking because people think of us as a developed nation, a sophisticated nation, a wealthy nation, and yet we've both traveled all around the world, and you see in Alabama and in Baltimore and places all over this country conditions that rival those in the developing world. And so it makes sense that we would borrow some of the things we learned, investing taxpayer dollars abroad, to bring those best practices back here and help us solve the problem better here. Which just sounds like what you're doing.
Right. Many folks feel, including myself, that a lot of the issue around retention is creating a trusting relationship with your provider.
Absolutely. Yeah.
And what we really do need to do is build off the service groups that already have trusting relationships. Unfortunately, the debate in the United States has largely been a middle class debate, and it has been sort of bloody, honestly. I mean, if you look at the recent debate around Affordable Health Care Act, there was very little discussion of people actually living with illnesses. And what's terrific about the Affordable Health Care Act, as you probably know, is it eliminates the pre-existing condition.
Right, which is very essential for people.
But I have to say, the ability of states to
expand the Medicaid.
To opt out of expanding Medicaid is the big hole in the plan, honestly.
I'm glad you're bringing this up, because when the Supreme Court ruled the Affordable Care Act constitutional, everybody in the community was saying, yay, like as if this was a done deal. And as you're pointing out, this is not only not a done deal, but the fight's just beginning. Because if the states don't expand their Medicaid coverage, then many people will go out without
I think
care.
Folks, from an activist perspective, first of all, the ACA passing is still, we would be in much worse shape if it didn't. But around the Medicaid expansion, people need to contact their governors. I mean, we've already seen the governor, I think, of Florida, the governor of Texas, already declared, we're not going to do this. And those are all the states, as you know, that have very high ADAP waiting lists, or have had. So we also, I just want to give a shout out to the Secretary and the President for eliminating the ADAP wait list. Hopefully ACA will create a structure whereby we don't have to worry about that as much. We also, the last piece of the retention program that we have funded is a $4 million grant to AIDS United to essentially fund innovative and effective retention programs at the local level.
Right.
And that has not really honestly been a focus, and we're hoping that the Global Forum can bring knowledge over that will be helpful. At the same time, we also realize that many providers already have these answers, they just haven't had the funds to make them happen. At the end of the day, people don't take their medication for really hard, some of it reasons. Some of it is poverty,
right,
and we have to help them address that.
Right.
Some of it is stigma, and some of it is issues around self-worth.
Yes.
And I think we have a non-judgmental, open and honest discussion about that. And unless we have, I think, a bridging of the gap of providers and funders and people living with HIV, we're not going to end HIV in this country. I'm lucky enough to be head of the Presidential Advisory Council on HIV and AIDS. We are on a treadmill trying to issue a report, which we will do by December. Really, we hope guiding the way, particularly around ACA implementation, to ensure that people living with HIV do better under the Affordable Health Care Act in terms of health outcomes and in terms of how they're treated than they're currently doing.